Assalamu alaikum. Today we are going to talk about some abnormalities in electrocardiography because we talked last times about the normal electrocardiograph. The abnormalities in electrocardiographies are called arrhythmias, and the causes of arrhythmias we're going to talk about are abnormality in rhythmicity of the pacemaker, shift of the pacemaker from the sinus node, and you remember the abnormal place of shift of pacemaker, we call it ectopic pacemaker. We are going to talk about blocks at different points in transmission of the cardiac impulse, and we are going to talk about abnormal pathways of transmission in the heart, and we're going to talk about spontaneous generation of abnormal impulses from any part of the heart. So these are the things we're going to talk about: abnormal rhythmicity, shift of pacemaker, blocks at different points, abnormal pathways of transmission, and spontaneous generation of hearts. Now, abnormal sinus rhythm, this is we call it either tachycardia. No, you remember that the normal heartbeat heart rate is between 60 to 100 beats per minute. So tachycardia is an increase in the heart rate if the heart rate is more than 100 beats per minute. Caused by what? Caused by either increased body temperature, because the body temperature increases the permeability of ions. Sympathetic stimulation. You remember sympathetic stimulation causes positive chronotropic effect and also causes positive inotropic effect. Chrono, heart rate, and ino, contractility. So sympathetic stimulation causes increase in the heart rate and increases in contractility, such as loss of blood and reflex stimulation of the heart, and toxic conditions of the heart that might cause some abnormalities. Toxic condition like hyperthyroidism, increase in the level of T3, T4, increase in the level of T3, which is the thyroxine, and T4. Remember here, if you count the heart rate from here, you take one that's almost there, this you take here, say this is here, and this is here, almost 10 small square. If it is 10 small square by 0.04, it means 0.4. So 60 here over 0.4, this is the time for one cardiac cycle, equals around 150 beats per minute, which means it is more than 100. And it looks like it is regular. It looks like that these heartbeats are regular. Okay, so this is tachycardia. Could be sinus tachycardia, which means if it is sinus tachycardia, you will find sinus node from P wave and QRS and T waves, PQRS T curves. SA etiology, SA node depolarizes faster than normal. Impulses conducted normally. Remember, sinus tachycardia is a response to physical or physiological stress, such as maybe primary arrhythmia or sympathetic stimulation. Abnormal sinus could be bradycardia. Bradycardia with heart rate less than 60. This, as you see here, from here to here, this is RR interval. You have 5, 10, 15, 20, 25, 30, around 35 small square, 35 small square by 0.04, which means it's very low heart rate. Very low heart rate is called bradycardia. So this is bradycardia. Presents in athletes sometimes. We will come to that because athletes, they have stronger heart, so their ability to pump blood out is much more than normal. So they don't need more heart rate to have a normal cardiac output. Because they have large stroke volume. So cardiac output here, cardiac output equals stroke volume. This is stroke volume, SV, stroke volume multiplied heart rate. Since those athletes, they have very high stroke volume, to have the same heart rate, they have the same stroke cardiac output, they have less heart rate. So they might have lower heart rate, but this is normal for these people. Can be caused by vagal stimulation. You remember vagus parasympathetic, and the stimulation of parasympathetic causes negative chronotropic effects. Example of which is carotid sinus syndrome, which means pressure on the carotid sinus. Bradycardia means low heart rate, less than 60. Presence might be in athletes, caused by also vagal stimulation. Sinus bradycardia. In sinus bradycardia also you have to record PQRST, as you see here. It's very slow heart rate, 1, 2, 3, 4, 5, 6, 7, 8, around 8 by 5, 40 small square by 4, 160. So this is very slow heart rate. SA node depolarizes slower than normal. Impulse is conducted normally. Normal PR interval, which means normal conduction between the SA node and AV node. QRS interval normal, but the rate is lower than 60. ECG here, normal and abnormal. This is the normal. As you see, this is P. Q, R, S, T, and so on. QRST. This is normal rhythm. This is nodal rhythm. No SA node. No SA node. This is no P here. No P here. No P here. This can be due to atrial fibrillation. Could be due to atrial fibrillation, or there is no nodal, there is no node, no SA node activity. There is no SA node activity here. You look to the P wave. Sinoatrial block, if there is a block in the sinoatrial node, and rare instances impulses from SA node are blocked. This causes cessation of the B, no P wave, and the new pacemaker in the region will be, in this case, is the AV node. As you see here, the heart rate will be between 40 to 60 per minute, which is the rate of the AV node. This is AV node rate. Okay, you should not have peace. ECG, this is heart blocks. What do we mean by heart blocks? If the AV node is damaged, it means that the impulse will not be conducted from the atria to the ventricle through the AV node. In that case, you will have a prolonged PR interval. PR interval. So this interval will be more than 0.2 second, more than 0.2 second, then more than 0.2 seconds. This is the interval. So this is P's here, P's. So the PR interval is very prolonged. This is, as you see, this is a so shaped زي أطراف المنشار هيك. So this is no QRS. This is called ventricular fibrillation. Ventricular fibrillation is lethal. Okay. So arrhythmia, conduction failure at the AV node, and there is no bumping action since there is no synchronous contraction of both ventricles. There is no bumping of the heart. This means that the cardiac output in this case is 0, and this is why it is lethal condition. Now we're going to talk about AV block. AV block, impulses through the AV node and AV bundle are slowed down or blocked. Why it can be blocked? It can be blocked because of ischemia of the AV node due to any reasons, either coronary ischemia or pressure. Be compression on the AV node by scar tissue or calcified tissue. AV nodal or AV bundle inflammation, which is rare here. It could be excessive vagal stimulation like carotid sinus syndrome, Stokes-Adams syndrome here. So in these cases, the AV node is slowed down. If the AV node is slowed down, the first thing is prolonged BR interval. BR interval should be prolonged. More than 0.2 seconds. This is the first thing. Okay. So impulse through the AV node or the bundle are slowed down, blocked because of ischemia of the bundle of the AV node or AV bundle. because of compression, because of inflammation, or because of excessive vagal stimulation. There are three stages or 3 degrees of AV blocks. Okay, we are going to talk about it after a while. So there are 3 stages, 3 degrees. First of all, incomplete heart block. That's first degree and second degree. They are incomplete. First degree. In the first degree, the PR interval is more than 0.2. Then PR interval from here 0.16 ممكن normal up to 2 up to 0.2. So the first things for the first degree is the PR interval more than 0.2, but each B is followed by QRS. First degree, that PR interval is more than 0.2, but each B is followed by QRS. Now here is the AV node. It's blocked. Sometimes here it's decreasing the conduction rate. So here, as you see here, this is the PR interval. It is more than 0.2. Prolonged B interval more than 0.2 seconds. But each B here, each B is followed by QRS. Each B is followed by QRS. This B, Q, R, S, T, T, QRS, P, QRS, T. So each followed by QRS, T. This is called first degree heart block. First degree heart block. This is first degree heart block. This is P, Q, R, S, T, P, Q, R, S, T, and so on. Remember, this is the first, this is the P here, from the beginning of B to the beginning of Q here. The PR interval is around 5, 3, and 2 as around 10 small square. So 10 small square by 0.04. Each small square is 0.04. This means that the PR interval is 0.4, which is more than 0.2. But each B here is followed by QRS. Each B here is followed by QRS. So this is first degree heart block. First degree heart block. Second degree heart block. PR interval is prolonged, more than 0.2. PR interval more than 0.2. But not each B. Some B's are followed by QRS. Some B's are not followed by QRS. Some P's are followed by QRS, but some P's are not followed. But there is a regularity that sometimes we have 3 B's for 2 QRS. Sometimes we have 4 B's, 2 QRS, or 3 QRS. You call it 3 to 2. The first number 3 to 2 is the number of B's, and the second number is the number of QRS, or 3 to 1, or whatever. but there is a regularity, that this irregularity repeats itself. So this kind of irregularity, it is called regular irregularity. So this is the second degree heart block. The second degree heart block, some impulses pass through the AV node and some do not pass. The one that passes through the AV node will have QRS. The one that they don't pass, they feel that there is drop beats. Drop beats. Sometimes the patient feel it as palpitation. يقول لك والله كأنه قلبي بده يوقع. إذا palpitation كأنه بشعر إنه there is beats, they are going, the heartbeats, and there is a beat that there is no beat. So he feels that as if his heart is going to fall down. This is called palpitation. خفقان. Okay. Atrial beat faster than ventricular beat, and there is regularity. That atrial beat, sometimes it is 3, we call it 3 to 2, say. Second degree heart blocks could be 4 to 2, 4 to 1, whatever. And I'm just giving examples. 4 to 1. The first number here, the first number is for the P's, number of P's. The second number here is number of QRS, ventricles. So this is second degree, and this is something that repeats itself. That's called regular irregularity. So this is regular irregularity. This is here. Look, this is P, Q, R, S, T. This is P, a second B. This P here is not for, this is drop beat here, dropped beat. This is another P, here QRS. T, and so on. So this is drop beats. This is blocked, this is conducted. This is here drop beat also. Dropped beat. Okay? Dropped beat. This is second degree heart block. Look here to this P followed by QRS. These two B's here, one P here and one P here. Here we have drop beat here. Here P's, here PQRST, PQRST, and so on. This is second degree heart block. Each successive atrial impulses encounters longer and longer delay in the AV nodal until and one impulse, usually third or fourth, whatever phase to make. This is drop beat. So this is a regular irregularity. This is 3 to 1 for whatever. Okay, this is the etiology is as you see here. that there is abnormality in the AV node. Sometimes it permits the conduction, sometimes not. If there is no conduction, there is drop beat. If there is conduction, there is beat. Third degree. In third degree, also the BR interval is more than 0.2, but there is no association between P's and QRS. There is no association. P's and QRS are completely dissociated. There is no complete AV total block of the AV node. P waves are completely dissociated from QRS. You remember here the heart rate will be below 40 because the heart rate below 40 beats per minute. Why? Because the heart rate now is from per kg. And you remember that per kg is between 15 to 40 per minute. So in cases of third degree heart block, the heart rate is lower than 40 and there is no association between P's and QRS, completely dissociated P's and QRS. Ventricles escape the nodal rhythm because the ventricle are not affected by the vagus nerve. This is third degree heart block. You remember PR interval are longer than normal and there is no association between B's and QRS. This is B, this is B, this is B here. These are P's, and so on. Etiology, there is complete block of conduction in the AV conjunction, so atria and ventricles for impulses independently of each other without impulses from the atria. The ventricle own intrinsic pacemaker, which is here the Purkinje beats between 15 to 40, which is Purkinje fibers. Purkinje, okay. Stokes-Adams syndrome, where you feel that there is pressure from the carotid sinus on the vagus nerve. In that case, if the vagus nerve is extremely stimulated, this will cause decrease in the heart rate, and the heart rate might be, this A node or V node might be suppressed completely. They are suppressed completely, there is no beating of the heart stops beating, but the heart stops beating for 15 to 30 seconds. After that, the Purkinje resumes its own rate, which is between 15 to 40. Why the Purkinje does not resume its own rate right away? Because this is a biological system, and biological system does not resume their rate, their activity right away. It needs some time. To start with, in the beginning, the Purkinje was receiving higher rate than its own rate, which is its own rate is 15 to 40. So if the Purkinje is receiving 70 impulses per minute, So the Purkinje will conduct 70 pulses per minute to the ventricular muscle. So the ventricular muscle will contract with a rate of 70 per minute. But now when the Purkinje, its own rate, the Purkinje own rate is suppressed. It is suppressed by what? Normally it is suppressed by the higher rate they receive it from the top. That's what we call it overdrive suppression. Overdrive suppression. So the Purkinje's own rate, normally it's suppressed by the higher rate they receive it from up. We call it overdrive suppression. But when this rate from the up, from the SA node or OV node stops, the Purkinje resumes its own rate. And why the Purkinje resumes its own rate? Because the vagus nerve, which is parasympathetic fibers, does not supply the ventricle, does not supply the Purkinje. So it does not affect the Purkinje. That's why the Purkinje resumes its own rate. Otherwise, if the vagus supplies the Purkinje, the rate, the heart will not resume any rate. So complete AV block goes, because it comes and goes when the carotid sinus presses the parasympathetic versus the vagus. When the pressure subsides, there is no suppression. Ventricle stops contracting for 15 to 30 seconds because of overdrive suppression, meaning they are used to atrial rate. Patients faint. Patients usually fall down because of no pumping activity, no cardiac output, poor cerebral blood flow. Then the ventricles escape the effects of the parasympathetic with AV node, AV bundle, and it resumes its own rate, the Purkinje, with a rate of 15 to 40. And when the heart starts pumping with a rate 15 to 40, say it's 30, 35, then the patient will get conscious back again, awaken, and things. Artificial pacemaker, the treatment for complete heart block. The treatment for complete heart block is to put a artificial pacemaker, and the artificial pacemaker is put from the antecubital vein and passes to the axillary, to the jugular, and to the right atrium, then to the right ventricle, and it is fixed in the right ventricular muscle. And these pacemakers are usually battery operated, and they can be fixed, hard fixed rate, or they can be changing rate, and the battery is put usually under the skin. And you remember nowadays the batteries can live longer time, says the batteries might not be changed for 8 to 10 years, and people can live on these artificial pacemaker normal lives. There is so advancement in the artificial pacemakers that some artificial pacemakers they change their rate automatically. Some pacemakers are fixed, they have fixed rate. So the artificial pacemaker is put from the antecubital vein of the right side to the axillary vein, but jugular vein, then superior vena cava, then the right atrium, then it passes to the right ventricle, and it is fixed on the right ventricle. And these artificial pacemaker are battery operated. Okay, the Stokes-Adam complete block, the heart stops for 15 to or 5 to 30 seconds because of overdrive suppression. Then the Purkinje resumes its rate, which is around 15 to 40. The patients usually, after it gets low, it faints, it falls down, يعني بدوخ بقع falls down. Why fall down? Because there is no cerebral blood flow. Okay, then the ventricle resumes its own rate between 15 to 40, and those patients with Stokes Adams sometimes or with complete heart block, what they need artificial pacemaker. Now we come to the mean electrical axis. You remember when we want to measure the mean electrical axis, you take any two limb leads, whether bipolar or unipolar, and what do? You just get the algebraic summation of the QRS, algebraic summation of QRS. Say this is lead 1, or you take lead 2 or lead 3. This is algebraic summation of QRS. So here they took lead 1, you remember this is 0, this is 180, and this is plus 120, 3. You take the QRS in lead 1, say in lead 1 it is whatever, you draw a perpendicular line, and you take the algebraic summation of lead 3 here, then you draw a perpendicular. They have to meet at some point. You draw a line from the center of the triangle to the points of transection, and this is the angle of the mean electrical axis, which is here minus 40 degrees, and this is left axis deviation. You remember here when we talked about the mean electrical axis, if it is in this quarter it is normal between 0 to plus 90 degrees. This is lead 1, and this is AVF. This is minus 90 degrees, and this is right axis deviation. Here is left axis deviation, here severe left or right. Remember this. So as you see here, this is a left axis deviation. So changes in heart position, because left axis deviation, maybe it could be during expiration, lying down, or excess abdominal fat. So here you can have left axis, maybe it could be normal position of the heart, here in fatty, short and obese people. But this could be within the normal range. احنا حكينا normal axis deviation is between minus 30 to plus 110. So this should be within the normal limits, but this is little bit causing some kind of left axis deviation. Okay. Right shift caused by thin and tall people. Thin and tall people can be having right axis within the normal limits too. Changes in heart position, left shift caused by expiration, lying down or excess abdominal fat, short and obese. Right shift caused by thin and tall person. Left axis deviation could be caused by left ventricular hypertrophy. Left ventricular hypertrophy by hypertension, aortic stenosis, narrowing of the aortic valve, aortic regurgitation, which is incompetence of the aortic valve, that the aortic valve does not close properly, that the blood regurges to the aorta, regurges to the left ventricle during ventricular contraction. Slightly prolonged QRS, because here, especially in the hypertension, because there is a lot of muscles here and high voltage. Look here, this is lead 1 and this is lead 3. You can take any two limb leads, just see the QRS, summation of QRS, and you draw perpendicular line here, and this is, you take a line from the center to the line of intersection. So this is the causes of left axis deviation, hypertension. This causes left shifts, aortic stenosis. In the aortic stenosis, the left ventricle has to develop a lot of pressure to pump that amount small about in a narrow orifice, narrow aortic valve. So the heart gets thickened, the heart gets hypertrophied, and this hypertrophy will cause left axis deviation. In hypertension also, that the heart has to develop too much pressure against the pressure in the aorta. Hypertension, it means that the aortic pressure is higher. This is what we called it afterload. Or during aortic regurgitation, during the ventricular ejection, part of the blood goes back to the left ventricle, so the left ventricle gets dilated. This is called cardiomegaly. Okay. Factors causing axis deviation here. This is right axis deviation. Hypertrophy of the right ventricle, which means that something in pulmonary hypertension, pulmonary valve stenosis. As you see here, this is lead 1. As you see, lead 1 is negative and lead 2 is positive. Negative here, this is perpendicular line, this is another perpendicular line, lead 3, and then you get left right axis deviation, that the right ventricle gets hypertrophy because of the pulmonary hypertension or pulmonary valve stenosis. Interventricular septal defect, sometimes when there is that the interventricular septum is not completely closed. It's called ventricular septal defect. The blood from the left ventricle at higher pressure is pumped to the right ventricle, and the right ventricle gets prolonged, it gets hypertrophied and gets dilated. If the right ventricle is dilated, you will get right axis deviation. All causes prolonged QRS and high voltage in the leads that are denoting the right side of the heart. Then hypertrophy of the right ventricle, right axis deviation, right axis shift caused by pulmonary hypertension, pulmonary valve stenosis, interventricular septal defect, that is called VSD, ventricular septal defect, that the interventricular septal is burst, is opened, so the blood goes from the left ventricle to the right ventricle, because the left ventricle has higher pressure than the right ventricle, and then the right ventricle gets dilated, and this dilation, hypertrophy or cardiomegaly, gets higher electricity. In case of left and right bundle branch block, left bundle branch block causes left axis deviation, and right bundle branch block causes right axis deviation. In left bundle branch block, just understand it like that. When there is left bundle branch block, it means that the right ventricle depolarizes first and completes its depolarization before the left ventricle, which means that most of the time there are currents going from the right to the left, because you remember the currents goes from the depolarized to the still polarized. So the current goes from the depolarized to the still polarized. The right ventricle depolarizes first, and then the left ventricle, since the left ventricle does not receive the impulse through the bundle branch, it receives the impulse through the ventricular muscle. And you remember that the ventricular muscle conducts the impulse much slower than the Purkinje fibers. The Purkinje fibers, they conduct the impulse around 4 to 5 meters per second. In contrast, the ventricular muscle conducts the impulse around 0.5 meters per second, which is very slow compared to the Purkinje. So in the right ventricle, in the left bundle branch, the right ventricle depolarizes, completes its depolarization, and then in the left ventricle still is depolarizing. So the current goes from the depolarized, which is the right, to the left. Or most of the current goes from the right to the left. In that case, we will have left axis deviation, that the currents going from the right to the left. Remember also, in case of bundle branch block, you will get prolonged QRS. So in bundle branch block, in left bundle branch, you get prolonged QRS and left axis deviation. On the other hand, on the right bundle branch block, the left ventricle depolarizes first, and then the right ventricle depolarization takes longer time. So most of the time, there are currents, there are vectors going from the left to the right. In that case, you will record right axis deviation and the same thing, prolonged QRS, because the ventricle, its depolarization takes longer time. So the QRS represents what? The QRS represents the depolarization of the ventricle. So bundle branch block, left bundle branch block causes left axis deviation, and right ventricle, because the right ventricle depolarizes much faster than the left ventricle, because the depolarization of the right ventricle is through the Purkinje and the depolarization of the left ventricle is through the ventricular muscle. QRS is prolonged. By the same token, the right bundle branch block causes right axis deviation, and the same thing, prolonged QRS. Okay, in a bundle branch block, this is the case. Now let's just review the ECG. ECG deflection, sinoatrial node, which is the pacemaker, and it denotes P waves. Then we have the atrial depolarization. This is sinoatrial node. Then QRS. QRS is ventricular depolarization. And within that wave, there is atrial repolarization that does not show up because it's been masked by ventricular depolarization, which is too much electricity. Then T wave, it is ventricular repolarization. Here. Okay. Okay, since at PQRST. ECG deflection, this is PQ interval or PR interval should be less than 0.2. QT interval, which is almost half of the RR interval, half of the cardiac cycle. Then you have the cardiac cycle around 0.8. If the cardiac cycle is 0.8 seconds, then the heart rate is 75 beats per minute. This is what we take as is standard for us for teaching purposes, but there is nothing called 75 beats per minute because the heart rate normally ranges between 60 to 100 beats per minute. So first degree heart block PQ interval is longer than 0.2. Second, you remember, second degree is longer than 0.2, but some P's are followed by QRS, some P's are not followed by QRS, and there is regular irregularity. And third degree heart block, which is called complete heart block, there is complete dissociation between P's and QRS. There is no association. It has B's, it's alone independently than QRS. So, but the heart rate here, if you take it, the QRS is less than 40. It's usually between 15 to 40 beats per minute. Enlarged or prolonged QRS here. This is as you see here. This is high voltage of QRS. High voltage QRS. This is hypertension, could be hypertrophy of the left ventricle. Irregularities, prolonged QT interval. Prolonged QT interval here. Look to the QT interval. Look here to the QT interval. And when it is prolonged, look to the QT interval here. Okay? Prolonged QT interval. Repolarization abnormalities, increases chances of ventricular arrhythmias. Elevated T, look to the T. Normal T, then look to when it is elevated. Hyperkalemia causes elevated T. This is the T, normal T. This is elevated T here. See how T is elevated. This is in case of hyperkalemia, higher concentration of potassium. Depressed T or flat T, this is the normal T. Look to the T here normally. When it gets flattened, this is flattened T. This occurs in hypokalemia or ischemia sometimes. You remember ischemia, you will have in case of ischemia here, you will have either depressed ST segment like this here, ST segment, or elevated ST segment like this. So this is the ST segment. Mainly when you look to the ischemia, you look to the ST segment, either depressed or elevated ST segments, And the isoelectric line is the TP here, isoelectric line, TP interval. TB interval is the isoelectric line. Increased voltage in the standard bipolar lead. Increased voltage, what you do, you summate the voltages of leads 1, 2 and 3, which will be longer than 4 millivolts. If it's longer than 4 millivolts, you can consider it high voltage in the EKG. High voltage in the EKG. most often caused by ventricular mass, increased ventricular mass, hypertension, marathon runners, whatever. So high voltage, you summate the voltages of lead 1, lead 2 and 3 should be more than 4 millivolts. This is considered high voltage. Most common in ventricular hypertrophy, hypertension, marathon players. Decreased voltage cardiac muscle old infarcts cause decreased muscle. Low voltage EKG and prolonged QRS. Conditions surrounding the heart, say fluid around the heart or fluid around the heart, either in the heart pericardium or in the lung, pleural effusion. So pericardial and pleural effusion. Fluid in the pericardium, you remember we call it cardiac tamponade, or pleural effusion, or emphysema, which is enlarged chest, enlarged lung, enlarged chest. That's a chronic smoker maybe. Cardiac muscle abnormalities, old infarcts, decrease in the cardiac mass, decrease in the muscle mass, low voltage and QRS, or the heart is further from the from the exploring electrode. If the heart is further, why the heart becomes further? Because there are some layers between that. Could be in the pericardium, could be in the pleural effusion, pericardial and emphysema, that the heart get too far from the exploring electrode. That's why you get. So the ECG is 12 leads. You remember the 3 limb leads, bipolar, 3 unipolar augmented limb leads, AVR, AVL, AVF. You have to remember the connections. And we have 6 precordial or 6 chest lead, V1 to V6. You have to remember their positions too. This is a complete ECG. And thank you very much. This is all what we need. Okay, thanks. Bye bye.